Greetings, everybody, and welcome to the School of Medicine and Dentistry's annual Med Talks event. My name is Jill Weimer. I'll be your host for this event, and I'm the president of the School of Medicine and Dentistry's Alumni Council. Normally an in-person tradition that occurs during Meliora weekend, Med Talks is an opportunity for us to share the innovative, collaborative work that occurs within the School of Medicine and Dentistry. We're delighted to be able to continue the tradition of bringing Med Talks to you virtually, and welcome to all of you today. It's my pleasure to introduce today's speakers to you. Speaking first about environmental factors that influence public health is Dr. Debbie Corey-Slechta, Professor of Environmental Medicine, Pediatrics, and Public Health Sciences. At the University of Rochester, Dr. Corey-Slechta has served as the chair of the university's Department of Environmental Medicine, director of the NIEHS Environmental Health Sciences Center, and dean for research at the School of Medicine and Dentistry. Dr. Corey-Slechta has served on numerous national review and advisory panels, including those of the NIH, the NIEHS, the FDA, and the National Center for Toxicology Research, as well as the EPA, just to name a few. In addition, Dr. Corey-Slechta has served on the editorial board of many journals. Her research has focused largely on the relationship between brain neurotransmitter systems and children's neurodevelopment, and how such relationships are altered by exposure to environmental toxicants. Speaking next about the allocation of scarce resources and data-driven ethical frameworks and lessons from the COVID-19 crisis will be Dr. Margie Shaw. Dr. Shaw is the interim director of the Paul M. Shrive Center for Bioethics, an associate professor and director of the Law and Bioethics theme at the University of Rochester School of Medicine and Dentistry. Dr. Shaw teaches at the intersection of law and healthcare, medical judgment and decision-making, and bioethics. She serves as a member of the clinical ethics consultation team. Her dissertation explored coaching as a form of instruction and as a component of medical ethics education. Her current research interests include law and ethics instruction in medical school curriculum and issues in applied ethical decision-making in healthcare. Previously, she served as the judicial administrator at Cornell University. She co-founded and served as the director of the Cornell University Computer Policy and Law Program, which is now the Cornell University Institute for Internet Culture, Policy, and Law. And now I will turn the program over to Dr. Corey-Slechta.
Well, good afternoon, and thank you all for coming. I'd like to talk today about a program that has been part of the University of Rochester now for 50 years that studies the role of environmental factors as they influence public health. And
Dr. Corey-Slechta, your slides are still in the presenter mode if you want to hit that swap.
Okay, sorry.
Again, it reverted back on you.
There we go. Okay,
Perfect.
Hopefully that's better.
Yep, that is perfect.
And so while we typically think about genetics as a primary driver of human health and disease, the reality is that for most complex diseases and disorders, there are a startling number of environmental factors that influence them. And this is a slide from the WHO showing environmental burden of disease globally. And I think you can see that it has a big influence. In fact, when we think about human health versus human disease, these environmental factors, first of all, don't occur in isolation. You are exposed to a variety of both environmental and genetic factors over the course of your lifetime. And these are what ultimately lead you to being healthy and or diseased as you age. And these can include chemical exposures, nutrition, your behavior, your sex, physical activity, smoking, etc. And again, they can occur both concurrently and or sequentially. With respect to the environmental chemical exposures, I think it's important to realize that there have been over 86,000 chemicals introduced into commerce. At the current time, there's over 40,000 of those that are active. And this table just shows you some of the classes of those chemicals. And within each of those classes, there are numerous different chemicals as well. And you are exposed to all of these chemicals. This is a slide showing you prenatal exposures to different chemicals. You can see on the bottom the number of chemicals to which individuals are exposed. You can see maternal blood had up to 40 different chemicals that could be measured in it. And similarly in cord blood, between 10 and 20 chemicals were being measured in this particular study. This is in utero. We think about some of these as having been problems that have been resolved. I think we're all familiar with lead poisoning and the story in Flint, Michigan of lead that was in the drinking water, but it's important to note that Flint was by no means a one-off, and this table is just a table of towns in Pennsylvania that have a far greater number of children with elevated blood lead levels than were seen in Flint. And sadly, with respect to lead, this is probably as good as it gets. We're not going to lower lead very much by replacing pipes at this point because it's in the soil and all kinds of other sources. Here's another one that shows you this concurrent use. These are 3 different pesticides I chose, and these are maps on the top. The first, the one on the left being paraquat, the one in the middle being glyphosate, and the right being 2,4-D. You can see their geographical use is highest in the Midwest, on the East Coast, and in places in California, and that these maps look very, very similar, which makes sense because these are pesticides used on crops, and these are areas where crops are grown. On the bottom, I think you can also see the increases in the use of those different chemicals. These are set in millions of pounds over the years. I think in particular, you can see increases in paraquat and glyphosate, which you may know as Roundup, whereas 2,4-D has already been high for any number of years. So again, just an indication that these chemicals are occurring concurrently. Your exposures are both concurrent and sequential. Okay. In addition to that, it's very important to note that these exposures are inversely related to both race and socioeconomic status. So on the left side, I'm showing you a figure from a paper in 2020 that shows air pollution, with the bigger dots being the highest levels of air pollution and the smallest dots the lowest, in different areas of Salt Lake. And here, again, the highest levels are in the inner city, lower SES gradients, where the lower levels of air pollution are suburban and surrounding that. And then on the right side, you can see the number of basically toxic exposure sites via the percentage of the population that is non-white. And you can see that as that percentage of the population that's non-white increases, the number of sites per square mile also increases. This is something that hits home here. It isn't just in other places. You can see that there's a 10-year difference in life expectancy, even in Monroe County, that equates with different zip codes and essentially different parts of the city slash county, with the lowest levels being in the inner city and the lower SES communities. So despite that, and something that we think about in the center that we have here is that our typical animal model studies and the epidemiology studies that are carried out generally only consider one chemical at a time and its impact on health, or one environmental stressor in isolation. And whether or not this is going to ultimately lead us to the promised land for cures or diseases is something that we could discuss. So again, I want to talk a little bit about the history of the Rochester Environmental Health Sciences Center. And this is a program that actually had its beginnings way back in the 1940s and 50s at the University of Rochester, and was funded by the NIH in 1975 and has been funded since that time. So we're now enjoying 50 years of progress in trying to understand the role of environmental stressors in human health and disease. And I'd like to give you some of the examples that have come out of our program. Some of them are way back from the 60s and 70s. Our expertise has been of critical assistance to other countries and continues to be. And here on the left side of the slide, you can see one of the first episodes, large episodes of poisoning by methylmercury. This occurred in Japan, where a company making felt hats was dumping methylmercury into the bay. That methylmercury was taken up by shellfish, which comprise a large portion of the diet of these individuals. And this was particularly toxic to pregnant women whose children were born with a kind of cystic fibrosis, as well as other kinds of deficits. And many of these children who were children at the time are still institutionalized today. Then in 1970s, there was another widespread mercury poisoning that occurred in Iraq. And this was because grain was sent to this country during a famine period. But unfortunately, the grain was laced with a methylmercury-based fungicide, and the icons used on the bag to indicate that poisoning were not familiar to this population. So they took the grain, made bread, ate this bread. And here again, it was particularly problematic for pregnant women. And we had another widespread component of mercury poisoning. We've also been very involved in the lead story. Just on the left side of the slide, give you a little bit of history of this. Back in 2000 BC, it was already known that lead was toxic. It was stated by Dioscorides that lead makes the mind give way. So it was well known at the time. And it was in 1887 that US medical authorities first diagnosed childhood lead poisoning. But despite that, in the 20s and the 30s, lead was introduced into paint and into gasoline. And it wasn't until 50 years later in 1971 that the Lead-Based Paint Poisoning Prevention Act was finally passed, and lead was removed from paint and gasoline. But it was here at U of RMC in our center that a large prospective cohort study was undertaken to determine whether what was then considered a safe level of blood lead, and that was 10 micrograms per deciliter, which hopefully you can see here, was actually safe for children. And so we looked at IQ levels in these children whose blood leads were below 10, and found that indeed we couldn't identify a blood lead that wasn't without adverse effects in children. And finally, by 2012, the Centers for Disease Control agreed with us and decided that there was no safe level of lead exposure in children that could be identified. So we've played a big role in that, and since in reckoning with it in our community. But again, going back to this multiplicity of exposures, this is particularly important when we have lots of environmental stressors at the same time, because it establishes a framework for interactive effects to go on. And in the case of lead exposure, as an example, it occurs most prominently in communities that are of low SES, where there are conditions of violence, neighborhood crime, poor education, resource deprivation, et cetera. And so how do those interact with something like lead exposure? If we're only studying lead exposure as a single variable by itself, as I showed you before, does it adequately reflect the level of toxicity when we think about these multiplicity of risk factors? And here's just an example of what happens when we combine something like lead exposure with prenatal stress, which is a community problem in many of these communities. And the blue group is the group that mice that got both prenatal lead and prenatal stress. And you can see, without even a great explanation of what I'm looking at here, that this group is very, very different from everybody else. And that when I put lead and stress together, I start getting adverse effects in this particular behavioral assay, which I don't see in lead alone exposures or prenatal stress exposures alone. So when we start thinking about these things together, we can have them unmasking effects or exacerbating effects. The same thing has been shown in human studies, where the level of stress enhances the cognitive deficits, the reduction in IQ that occur in conjunction with lead exposure. So this is not something that simply occurs in animal studies. Another area in which we've been very much involved is the whole problem of air pollution. This is simply a slide that shows you some of the world's most polluted cities, and you can, I think, easily see the haze in some of these cities that occurs with air pollution. The center has had, since its inception, an inhalation facility and scientific leadership in this area. And this inhalation facility allows us to expose either humans or animals to ambient air, which we pull in from outside into this facility to do these studies. And one of the things that we know about air pollution is that it too is a mixture of toxicants. And you can see on the right side what an air particle looks like. It has a core of carbon, and it adsorbed onto that are all kinds of toxic metals and organic elements. In fact, air pollution is all about particle size. And here I'm showing you a human hair in the gray. And we think about air particles in three different sizes. The yellow are what we call coarse particles. They're 10 microns in diameter or less. The blue are fine particles. Superimposed here on the yellow, they're 2.5 microns or less. And these red particles are nanoparticles, which I'm sure you've heard of, or ultrafine particles. So you can see how small they are. And these ultrafine particles are considered the most toxic component of air pollution because they have the most surface area to adsorb all those other contaminants and deliver them to you. And unfortunately, EPA right now only regulates the coarse and the fine particles. So what's the problem with that? First, our center has had leadership for many, many years in understanding the cardiopulmonary toxicity of air pollution. And I believe air pollution right now is considered the 5th leading cause of death in the world. And you can see, going way, way back, our involvement in many of these studies. As we've moved along, we've begun to look at the brain as a target of air pollution, and epidemiology studies have already associated air pollution with autism, schizophrenia, attention deficit disorder, with neurodegenerative diseases that include Alzheimer's disease, Parkinson's disease, ALS, and MS. And Going forward with that, if you just look, for example, at autism spectrum disorder, here is a slide showing you the rate of increase in its diagnosis over the years. Clearly from the 1970s to 2018, this cannot be genetic. Genetics cannot explain this kind of a rate of increase. So how do these things contribute to brain disorders? Well, you have to remember, once again, your susceptibility to these particles starts in utero. Ultrafine particles or nanoparticles can pass directly from the bloodstream, from the lungs into the bloodstream. In a pregnant woman, they can cross the placenta and get directly into the fetal blood, or they can influence the placenta, resulting in dysfunction. Once you're born, there are multiple routes of particle entry into the brain. Again, the particles get into the blood. They can then travel via the vagal nerve or other ways into the brain, but you're also exposed via direct airborne inhalation. You literally breathe these particles up your nose, excuse me, and they go directly into the brain. They bypass the blood-brain barrier. So it's a lifelong exposure. Once there, this is an example of how those kinds of exposures can alter the metals that are in the brain, produce what's called brain metal dyshomeostasis. You can see very high levels of iron, sulfur, copper, calcium, and even aluminum in brains of mice after these kinds of ambient exposures to ultrafine particles during development. In addition, we can see very male-specific neuropathology in these brains. Here's a brain of a normal male mouse at 14 days of age, but I think you can see after the ambient exposure to the ultrafine particles, what's called the lateral ventricle of the brain is still very wide. This is a phenomenon called ventriculomegaly. Wasn't produced in females, only in males, which is interesting after these developmental exposures, because many of those neurodevelopmental disorders are also male biased. And in fact, ventriculomegaly is something that can be seen in an ultrasound and is considered a clinical indicator of a poor prognosis for a child. In fact, you can see ventriculomegaly in children with autism spectrum disorder across the life. You also see a reduction in the white matter of the brain in males, but we're beginning to see latent effects in females. And here's an example of that, how it might relate to dementia. We know that as you increase levels of air pollution, we see an increase in the risk of dementia. Alzheimer's is a female biased disease, and even in normal females without dementia, as air pollution increases, there is a loss of what's called white matter in the brain, which connects the two hemispheres. In addition, in animal models, we're already seeing increases in two of the primary markers of Alzheimer's disease, and we see it only in female brains, which are the beta amyloids and the tau proteins. And finally, in the females only, we begin to see the loss of neurons, again, providing biological plausibility for these associations. So in summary, I'd like you to remember that the environment is critical to the trajectory of human health and disease. These environmental stressor effects can begin in utero. They can include chemicals and other environmental stressors that can interact with each other, as well as your genetic background. And it's clearly understanding these cumulative risks, these interactions, that's going to be critical to curing diseases and disorders. Thank you very much.
Excellent. Thank you, Dr. Corey-Slechta. I think we'll start off with a few questions that were sent in advance of the lecture. So the first one pertains to Roundup, the glyphosate. And so this has been a hot topic, and there's been a lot of research around it, but a lot of folks in the community really believe that it's all or nothing, and it's the only chemical that they should be concerned about. What are your thoughts about sort of how we communicate with the general public, and whether this is really, from a farming perspective, the only chemical that we should be worried about that's used in farming today.
Well, it's hopefully you could see by what I presented that it's by far not the only chemical that we should be worrying about. Even from a farming point of view, plants are starting to develop resistance to it. But glyphosate has actions on immune systems, reproductive systems that it shares with other pesticides that are also being applied, as well as other chemical factors. So again, we need to worry about how it might interact with those and produce effects where glyphosate alone might not even have an effect. But I think we're also still in the trajectory of completely understanding what its effects are and what its human health risks are.
Excellent. And I would just remind our attendees that if you do have questions, feel free to drop those into the chat box and we can answer those live. I'll go to one of the additional questions that was sent in advance. And this really kind of centers around the treatment of functional disorders. So, one aspect of sort of environmental toxicants is the prevention of these, but in situations where we have these and developmental disorders are hard to reverse, but with some of these, how reversible are some of these functional disorders? Can you, for instance, rebalance the metal brain that you mentioned and sink out some of those metals out of the CNS and change some of these disorders?
It's very difficult to do the latter. I know people have proposed doing what's called chelation therapy, which could pull metals out of the brain. Unfortunately, very few of those chelators are specific for any given metal, and they can't always get to the compartments of the cell where those metals are being most problematic. Obviously, prevention is the best cure, but the question about interventions is interesting because the brain is plastic, and if we could devise behavioral interventions that could undo some of the damage, those would be very helpful. Unfortunately, there's been very little work in that area. Here we are with lead all these years, and we still don't have interventions that are specific for the kinds of deficits that are being produced by lead, nor are they being implemented. So I think that's a wide open area, and I would love to see more work going on in that area.
One of the things that you mentioned early on in the timeline and the history of the center is sort of the 50 years of continued support that the center has had from the NIH. And I applaud the team for maintaining that because it's not an easy feat. But I think, too, it's important to step back and realize that many of these studies happen over decades, right? And a lot of times our funding cycles run in like 3 to 5 year funding cycles. And so, how do you view, sort of from a leadership perspective, ways to pursue funding to support studies where that there's been an exposure, but it may be decades before you see the outcomes and the changes? And how do you build a program around that?
Yeah, it's very difficult to do that because, as you said, you have exposures, but you don't have some onset of a disease or disorder for 15 or 20 years. There are things that are going on that are starting to help us. I'll give you an example of air pollution. So data has been kept on air pollution with monitors all over the country for many, many years. So now we can begin to go back and look at those exposures over time and superimpose them, for example, in geographical information studies on top of areas of high diagnoses of some disease and disorders. With respect to pesticides, California has this wonderful database where they've kept track of every applicator and what they've applied over the past X number of years. So that allows us to build bridges to go backwards. Moving forwards, what's really critical is supporting these prospective studies that typically are going to end after 5 years, to be able to go longer and longer with these cohorts so that we can begin to see effects that might manifest later on. And the other thing is supporting more basic science research that looks at what's called the fetal basis of adult disease. So when you reprogram inadvertently something in the fetus, how does that manifest later on?
Correct. And I think, too, then there's a question from the audience pertaining to sort of that transition and how we model these diseases in animal models. And the question is really about, from a government perspective, how concerned are you with grassroots efforts plus Congress that some of the tools that we use in basic biomedical science, such as animal models, might be taken away or limited before the science is ready for answering the questions that we have?
I'm very concerned about that. That has been a big push, very much so in the world of environmental toxicology. Everything's going to suddenly be done in a dish. I have seen very little in the way of validation of a lot of the in vitro assays or organ on a chip. I don't know how you would model some of the things like stress in a dish. You cannot, even in animal studies, you can expose animals to corticosterone, which is a stress hormone, but that's not the same thing as the animal actually experiencing a stressor. So I personally am not very, I'm very concerned about this direction. And I do a lot of work right now for EPA risk assessment documents, and we're not able to use data from in vitro studies to set risk levels for humans because there's no way to extrapolate the concentration in a dish to what humans are exposed to. So I am very concerned about that.
Yeah. And then I'll just ask one last question, and it goes back to the data that you presented on sort of the pollution exposure leading to a lot of these neurocognitive changes. Are there studies that directly show causation of pollution effect on autism prevalence? And do you think that one of the sort of driving factors behind this uptick in autism prevalence that we've seen over the last several decades is around public awareness, education, and diagnosis in testing for autism, or is it purely driven by these environmental exposures?
Well, I think it's partly driven by changes in diagnosis, and people have shown a little bit of that. But I don't think that can explain the whole thing. In animal models, you're never fully replicating something like autism, but you can look at the markers that we can look at that are the same in what we see in humans. With respect to epidemiology, I think there's almost 20 epidemiology studies right now which have found an association between air pollution. They've been in different countries, different levels of air pollution exposure. So to me, that keeps building strength for that. And the fact that in animal models, we see this male biased effect, I only showed you one, but we see many different features that are also components of autism spectrum disorder in humans. So again, that provides the biological plausibility for this kind of a thing. Air pollution is basically an inflammation of the brain, and brain inflammation has long been known to be a risk factor for autism. So that's a mechanism by which that could occur.
Absolutely. Well, thank you very much for your time today and your presentation, and good luck with your research.
Thank you.
Thank you. And I will now invite Dr. Shaw to share her presentation with us.
So I want to, first of all, say I'm delighted to be here, and thank you for the introduction, and Dr. Koresh-Lechter for that really interesting presentation that preceded mine, and in some sense provides a good background for what I'm going to talk about today. I want to start by saying I wish that y'all were here in Rochester. It is a beautiful day, and I hope for a day soon that can bring you back to campus. Thanks for coming. I want to talk about ventilator allocation, our process of ventilator allocation decision-making, and it's grounded in sort of who we are and why that matters. And so I'm going to start with a confession about who I am. I am somebody who does not like horror movies. And as a professor of ethics, I'm skeptical about trigger warnings. Every conversation that I have is potentially traumatic for somebody, and we never know what trauma is in the room. But today's talk is about something that is still raw with many people, and also quite real and quite heart-wrenching. So I want you to be prepared. I'm going to talk about it in a particular way, though, to give you a sense of what we went through at the University of Rochester and how we thought about a potential shortage of a life-saving technology. And I'm going to do it in the context of sort of these 3 points. I want to talk about place, our place, the people here, our community, and probity, who we are as an institution. What are the values that we hold and which ones that we hold so deeply? So of course, we're the home, the proud home of the biopsychosocial approach to medicine. It's really important that we are grounded in this approach. We know the work of George Engel and how he understood the interconnectedness, which is why the presentation just before this was a perfect segue. We know how related we are and which of these perspectives we're considering, whether you're looking at the cells or if you're looking at the atmosphere. Not only are you looking at something different, but you're looking at something that is related to all of the others. And so I'm going to talk a little bit about perspective. And as somebody who teaches ethics, I value how we think and how we see. And I really like this quote from Nancy Sherman from The Fabric of Character. She's a philosopher who works with Aristotle. And what she says is, it is that our judgment of particular cases and our knowledge of how to compose the scene is itself part of the moral response. In this sense, character is expressed in what one sees as much as in what one does. Knowing how to discern the particulars, Aristotle stresses, is a mark of virtue. And so what one sees is a critical feature of what I want to talk about today and how we see what we see. And so I want to remind us about beautiful New York and the geodiversity of this state, and not just how diverse we are, but also how connected we are. And we're connected in many ways, not just by roads, but by water. And that's not only are we connected today, but we've been connected over time. And so these are some images. We're connected historically. And so these are some historical images. You'll recognize the maps of the Erie Canal. The map on the bottom left is how cholera came to the United States and how it traveled in different places. And so it's this history of understanding in upstate New York how we are particularly connected to the rest of the world and particularly connected to downstate New York. And so it was in the we had an outbreak here in 1830s. That was the cholera outbreak, which led to actually the city of Rochester tapping into 2 of our Finger Lakes to provide clean water for our citizens. And so it's this history where we experienced disease that came to us through the Erie Canal. And that was work that was done by Dr. Lewis Beck, the report to the New York governor at the time, Governor Thorpe, which precedes the map of cholera across the Erie Canal and the outbreaks along the path of that canal. And that predates the really well-known landmark work of John Snow in the 1850s that shows the power of image in understanding data. But this was in the late 1800s, and this history, and I'd like to acknowledge the photograph on the bottom right. This was in a medical school textbook before the University of Rochester was founded, and depicting an image of a victim of cholera and trying for the help of diagnosis. This may be too much history, but it grounds us in understanding how connected we are in upstate to our downstate colleagues. This history grounds us to our experience that we've just had. So I want to bring us a little closer and think about more recent history. So in January 2020, it was when the WHO announced this mysterious coronavirus-related pneumonia in Wuhan, China. Seems like so long ago, and yet January of 2020. And it was February that the US declared a public health emergency. And in March, President Trump declared the COVID national emergency in the United States. I want you to remember March and April of 2020. The headlines, New York Times at the top of the COVID-19 curve, how do hospitals decide who gets treatment? CNBC, there's a shortage of everything. AP News, who had warns worst of the virus is still ahead. And stat, people are going to die. So in upstate New York, we are reading the news, we're seeing what's happening, and we're talking to our downstate colleagues. And we're understanding that our downstate colleagues are making life and death decisions at the bedside. The time that we're focused on is this time I've highlighted with the red oval. So these are the deaths in New York City each day. And the story that I'm telling today is all occurs within that red circle. What we heard was that individuals were dying because there were not enough ventilators. And so bedside clinicians were having to make decisions about which patient would best benefit from a ventilator. And we had concerns about those kinds of decisions being made at the bedside for so many reasons. And I want to highlight the leadership at the time, Dr. Rich Demi and Dr. Chris Reynolds. Dr. Reynolds is the head of ethics at Rochester General Hospital in the RRH system. And Dr. Demi recently retired from the head of the ethics committee at the University of Rochester Medical Center. And they collaborated. It's these two individuals who get tremendous amount of credit because they're the ones who recognized that we needed to do something as a community and do something very quickly. And that something was, look at how one fairly allocates, justly allocates a limited resource in the worst case scenario. And they knew each other because of the wonderful work that's happened at the Rochester Academy of Medicine. So this speaks a little bit to Rochester and the sense of community here and our long history of working together for the health of our community across systems and across hospitals. And at the Rochester Academy of Medicine, there was a wonderful donor, local physician funded the beginning of a healthcare ethics leadership consortium, which was designed to provide education and leadership across the region to elevate the conversations that we were having so that we could help each other and in the work that we're doing at our different institutions. And so Dr. Demi and Dr. Reynolds had met during their participation in the Healthcare Leadership Consortium. And when and they called each other at the beginning of the pandemic and said, what are you doing? What do we need to do? And so what we needed to do is have a plan. And I don't know how many of you have seen the YouTube video, the advertisement that I have as an image of the plane that's being made in, being built in midair. I started to show it, but it's just too light of it's too light when talking about a topic like this. But it's exactly what Dr. Chin-Lin Ching talked about when she was describing her experience as being part of the coronavirus ethics response group, which was the University of Rochester's response to this. And she said, in the spring, I would hear the phrase, we're flying the plane as we're building it. Not only that, but we didn't, excuse the typo, we didn't have instructions. And the plane was nosediving into the side of the mountain. We had we just felt the pressure of what we were doing. And the pressure of what we were doing, we're making decisions about the use of technology that was going to immediately affect the lives of patients. And so what I'm focused on now are the people and how many people came together to think about what was the best way to do this and what's the most appropriate way to make decisions. This is a membership listing of just the core members of the coronavirus ethics response group. Dr. Demi, when he pulled our group together, not only included Dr. Reynolds from the RRH system, but he included, there were over 60 people in the initial meetings and 80, and these are 80 people, and over the course of the entire coronavirus ethics response group process, there were probably hundreds of people who participated and contributed to the document that we produced and made it possible for us to do what we're doing. And so the number of people and how we came together is really quite remarkable. And I want to highlight the structure of the coronavirus ethics response group. It was that we pretty early on created subcommittees to provide the background work and the existing work that we needed to do to make this protocol be able to implement this protocol. And so we had an external document review committee that worked on making sure that we grounded our work in the existing literature about resource allocations. And we relied on the New York State ventilator allocation protocol that was created for the flu influenza. That protocol had never been implemented, but the core ethical work and the foundations were really useful to us, especially when we had such a short time frame in which to come up with a plan that we could implement here at the institution. And so we had that background work going. We also recognized, and this is Dr. Corey-Schlecter's presentation highlights, that we recognize that individuals who were previously and currently underserved and marginalized have higher risks and will be disproportionately impacted by the recommended protocol from the New York State of using the sequential organ failure assessment, the SOFA score, in determining priority. And so we knew that our systems had baked in discrimination for those who are underserved, and we needed to think about how we could address that. And so we knew immediately that if we're going to make decisions that are going to impact individuals in our community, like ventilator allocation, that we needed to include our community members in conversations about how one ought to do that. I am most proud of being a faculty member at the institution that made the decision early on to include community members at every single step of this process, from the early planning to the implementation, if we were ever going to have to do that. And we had community members embedded throughout this process, helping make sure that we considered this from all different perspectives. We had internal communications committee, and thinking about how one has conversations about time trials of ventilation and limited availability. And so we partnered with our palliative care colleagues, and we partnered with the leadership at the University of Rochester Medical Center's advanced communication teaching. And we had a special group on communications that was on communications teams that worked with our critical care colleagues. We understood, because we were experiencing ourselves, and we understood that our clinical colleagues at the bedside would be experiencing this if we ever had to implement this protocol, that there was going to be incredible moral distress, not just because of the influx in the nature of the illness, but the decisions that we were going to be asking them to make, or we were going to be making and asking them to implement. And so the team created a multifaceted approach and collaborated with Department of Psychiatry, Employee Assistant Program, and chaplaincy to think about how we were going to manage this to maintain the well-being of our community members while we went through this process. The Protocol Development Committee, this was the team that analyzed real-time data of our COVID positive ventilated patients and applied that data and looked at that data and assessed it using various algorithms to make sure that we were utilizing an algorithm that actually resulted in the goal that that the committee had adopted as the goal of our work, which was to in fact save the most lives. And as I indicated, the New York guidelines had never been implemented, and they were developed for influenza. So we didn't understand the pathophysiology of COVID when it first came, and we were concerned about how do we make sure that we apply the medicine, apply the care that will result in the most life saves. And in this work was benefited. It was only really possible because of our collaboration with the translational data and informatics team. We utilized this collaboration with our CTSI colleagues. They have a biolab informatics system. The BLISS was a centralized data integration and a management system that we used, and they created a new database as well. They interfaced this with our existing patient Epic software. They used a previous URMC quality improvement project, all of this to automate a SOFA scoring, which would give us real-time data so that the decisions about prioritization would be grounded in the actual status of the patients in the moment. We're not aware of any other institution in the United States that did this work. It really indicates what a special place the University of Rochester is because of our prior commitments to translational clinical research and translational research, and our prior commitments and relationships to work together. So we also had triage committees. We trained our triage committees. We were prepared to implement this work. I'm really thankful that we never had to do that. We also had a protocol assurance committee. The protocol assurance committee was designed to make sure that we continued to review and ensure there was data validity and consistent methodology and implementation fidelity, that we wanted to make sure that as we did this, that we did this in a fair and unbiased way. It's really quite remarkable work. And I started with the BPS approach to medicine, and it's this understanding that science and technology is employed, that we use science and technology, and we use it in the care of our patients and the care of each other. So what I'm most proud of, and of course I am as somebody who teaches ethics, is that I'm most proud of in this moment, in a place where we understand that crisis uncovers character. Well, every day uncovers character as well. And I think this picture illustrates it with the intense use of technology and understanding of science, all directed at the care of patients and for each other. And so we focus on our personal values, our professional values, and our institutional values, because that's in fact who we are. So our lessons, so we learned that many hands are necessary, that collaboration is so important. And I want to really emphasize that these aren't new lessons. I mean, what made this such a wonderful and intense experience is because we didn't have to utilize it, but also that it showed us where we work. It showed us the values of the place that we work, and that we understand that we need to attend to the structural injustices that exist in our world. And it led to supporting work that's happening through our Office of Inclusion and Diversity and Equity, our Office of Inclusion and Equity, and our Equity and Anti-Racism Plan. The two images at the bottom are the ones that really encapsulate the message that I want to make sure that we focus on, which is that we were prepared. We sit in an institution and work in an institution and studying in an institution that has already done that hard work. We're constantly making progress, working on discoveries and making the world a better place. And it's by relying on that existing work that let us be in the position that we could do what we did for the coronavirus ethics response group. But it's also the ASAP, these of course ASAP fables images, but it's the one on the right, the mice, that's also critically important, is that this is not theoretical work. It's not enough to just think about what's a solution or the right way to do it. This is work that we apply every day to make sure that it has to work, and we apply it every day in the care of our patients, in the care of each other. So if you want to know more about the work that we did here, I recommend that you read Sally Parker's article that was in the Rochester Medicine Special Edition in 2021. It gives you a sense of what we did and how we did it and how hard it was, but also how remarkably lucky we are that we work in a place with such incredible colleagues. And so I open it up for questions and comments. We can talk about what we did and how we did it. Thank you.
Excellent. Thank you, Dr. Shaw. So I'm going to start with a question that was sent in, and I think this actually goes beyond sort of even what you guys did, but how you use this going forward, particularly in teaching of students. So I think the pandemic has really transformed how we teach, but the question is around how the lessons learned from the COVID-19 crisis are being actually integrated into our curriculum moving forward, and how you actually envision this being used and how we train and teach our medical students.
Sure. So we've done this in a lot of ways. First, with medical education in the medical school, when this first happened, there was an increase in request for courses that address the ethical issues around justice and resource allocation. And so we created multiple electives for our students so that they could go through this process as we were, and learn about the process as we were, and to think about the different moral theories that one can apply in these circumstances and how one can address that. We offered courses on perspectives around different individuals and how they might perceive decisions to allocate resources in different ways. So we offered courses on perspective taking. Our medical school did a review, continues to do a review on the curriculum with an equity lens to make sure that we're addressing the issues that were uncovered that we already know exist. And so that was in the medical school, but we've also increased our, so as we started, I work in the Division of Medical Humanities and Bioethics, and we've increased our footprint into the hospital with requests with different departments to help think about these issues. And so the Department of Medicine was the first to reach out to us and asked us to participate in their anti-racism curriculum with books that they were reading to try to enlighten each other and to learn more about what we can do better as individual providers. We're currently offering with the Department of Pediatrics, Obstetrics and Gynecology and Family Medicine, a 9-week elective on maternal health, shifting perspectives and addressing bias through a history lens. Addressing Black maternal health using Dorothy Roberts' Killing the Black Body book. And so we have had so much wonderful interest in different areas across our institution. We're offering an elective, actually we're offering a required course, a pilot required course to our PhD programs on human values and research. And so the coronavirus it indicated lots of things to us, but one of those was the importance of ethics. I mean, every decision is a value decision. And so how do we make sure that we include that in all of our education from the very beginning and through lifelong learning?
And I think too, you hit on medical students and PhD students. Are there particular things that you're doing with the School of Nursing too, since a lot of times they're the frontline workers interacting with the patients?
So we have not, in our division, we haven't reached out. We've done some guest lecturing, and we have faculty. We haven't reached out to create courses because of their content is so full. But we have faculty who in the School of Nursing who also work in the Division of Medical Humanities and Bioethics, who teach ethics in the School of Nursing. And those faculty integrated the same teaching that I'm talking about for medical students in the School of Nursing. But we also, the work of the Moral Distress Committee, I mean, so all of those committees that I mentioned, and the reason I focused on those is those continue to exist today. The Moral Distress Committee, we restructured the Hospital Ethics Committee following this to make sure that we were more inclusive. We included we sent out an announcement to UR Medicine wide to encourage volunteers for a handful of spots on the ethics committee. Over 60 people submitted an application expressing an interest. And so we have created roles for all 60 of these people. So we now have subcommittees in education and staff support and policy and community engagement. And so it's an outpouring of people who want to be involved and make a difference. And so there are lots of places that we are continuing to reach.
Yeah, that's exceptional. And the concept of, like you need all hands on deck during a situation like this. And so how to utilize them and put them, deploy them and get them to work. I applaud your efforts. I think in the interest of time, we'll end there. And I want to thank both Dr. Corey Slechta and Dr. Shaw for their presentations in this Med Talk today. I also want to thank all of you for joining us. Please watch for a survey that will come from the university, as well as a copy of the recording of the presentation. And then please just make sure you stay connected with the School of Medicine and Dentistry by joining the Meliora Collective, and that interactive university online networking platform is a great way to make connections, but also stay up to date on events like this that you can participate in. So thank you all for attending, and thank you to our speakers.
Yeah, thank you.
Thanks.